Greetings and welcome everyone to today's On With Life webinar on peeling back the onion layers, cognitive defects following left hemisphere stroke. My name is Dave Clark. I'll be your host for today's event. This is the 6th webinar in our series of stroke rehabilitation webinars. If you missed any of the earlier webinars in this series, all of them are available on the On With Life website. There's no cost to view any of the webinars, and each webinar is good for 1 contact hour of continuing education credit. After you viewed a webinar, just complete the evaluation form and you'll receive your certificate. All right, well, let's get started with today's presentation. Today's featured presenter is Courtney Huber, a speech-language pathologist at On With Life. A native of Saskatchewan, Canada, Courtney received her Master's of Science in Speech-Language Pathology from Purdue University in 2005 and has worked in the field of acquired brain injury for 13 years in long-term skilled, inpatient, and outpatient levels of care. Courtney has worked with On With Life since 2011, and her area of interest is executive dysfunction, with emphasis on community reintegration, return to work, and role changes following brain injury. So as our featured presenter today, Courtney will take it from here. So with that, Courtney, over to you.
Thanks, Dave. And I'd like to welcome all of you to the next installment in On With Life Stroke webinar series. I'm really excited to be able to talk for the next hour on cognitive deficits that follow left hemisphere stroke. And I'm hopeful that the information provided today will enrich your assessment and treatment of individuals post left hemisphere stroke, especially those with resulting aphasia. So first, I just want to briefly summarize the objectives of the webinar. So during this hour, we will be discussing specific and underlying types of cognitive deficits that may present in an individual following left hemisphere stroke, discuss factors that may influence the likelihood of a person acquiring cognitive deficits post left hemisphere stroke. We'll talk about types of assessment tools that can be utilized alongside language assessment with this population, and conclude with intervention techniques that can be considered for persons with aphasia secondary to left hemisphere stroke. So I really want to illustrate these concepts of cognitive impairment and intervention by presenting a case study. So for all of you, I'd like you to all meet Dwight. Whoops, no, not that Dwight. Here we go, this Dwight. So Dwight suffered large left hemisphere ischemic stroke in April of 2018, so just over a year ago. And as you can see, prior medical history is significant for essential hypertension. I see the word benign in front of it. I don't think that that's a good descriptor, but I'm not a doctor here. Prior to his stroke, he worked for many years in IT for a major agricultural company. So when Dwight came to us at On With Life's outpatient neurorehabilitation program in January 2019, he actually just started with occupational and physical therapy with us. His speech therapy services were still being elsewhere, but then he made the decision to transfer his speech services to On With Life in February. And when I first got the opportunity to meet Dwight, he talked a lot about having difficulty finding the words that he wants to say, that oftentimes we would see him trying to write out the word on the desk or in the air as a way to help him try and get to those exact words. But on top of that, he was also having difficulty with object recognition, delayed memory, and overall attention. As I was going through his initial reports from occupational and physical therapy, one of the things that was really striking to me was that in his initial physical therapy evaluation, there's an assessment called the TUG, or the Timed Up and Go test, and it's completed under 2 different conditions. One is done without any distractions, and the other is completed while the person is counting backwards by 3s. And it was noted that in that second condition, so when he was having to count backwards by 3s, there was nearly a 200% increase in the time that he needed to complete this task. That's nearly 4 times as long. So when speech therapy completed initial assessment, we decided to do both a standard aphasia battery, and we also wanted to do some overall cognitive communication evaluation. So when we did the standard aphasia battery, it confirmed that he had mild anomic aphasia, so the term that we use in speech and language pathology to describe somebody who has a really hard time finding the words that they want to say. It was interesting, though, when we did the cognitive communication testing, because there are several tasks within that testing that don't have a high linguistic load. And what these tests were indicating was that he was showing moderate to severe impairments in his short-term memory, his visual, spatial, and constructional function, and attention. And what we'll do is we'll talk later about how the assessment data we collected helped to formulate our plan of care. But for right now, we really need to look deeper into what's going on. And I really want to pose a challenge to you attending today, and that is to look at a statement from the National Aphasia Association regarding the relationship between language and intelligence. And the reason why I've included this is because I think that many of us, and I include myself in this, especially in the early days when I started as a speech language clinician, sometimes we make that assumption that a person with aphasia secondary to a left hemisphere stroke has intact cognition. But I challenge you, as you continue to listen in on this webinar, to take this with a grain of salt. So we really need to look at all of the components that comprise intelligence and peel back the layers. And we find that in the population of individuals with aphasia post-left hemisphere stroke, there can be bona fide measurable deficits in underlying cognitive processes that can affect not only an individual's response to aphasia therapy, but also affect return to activities of daily living and typical life roles. Trying to figure out the relationship of language and cognition is extremely muddy, as we all know, and there is no good consensus. So here I presented three main trains of thought regarding this relationship. So as you can see in the upper left-hand corner, there is one train of thought that suggests that language and cognition are mutually exclusive and that changes in one system have no effect on the other. If you see over in the upper right-hand side, this train of thought suggests that language and cognition are one and the same, and there's no way to pull the two apart. And on the bottom, the third train, and this is the model that I tend to utilize in my clinical practice, is that language and cognition do have some individual and some exclusive neural systems, but there is also a lot of overlap between the two. When figuring out the relationship with language and cognition, we also need to take a look at neuroanatomy, especially as it pertains to left hemisphere stroke. So on this side, you see a pretty classic diagram of the left hemisphere of the brain with the major speech and language centers that are highlighted. So Broca's area, Wernicke's area, the angular gyrus, and the arcuate fasciculus. And we know that this mapping is generally true of about 90 to 93% of individuals who are left hemisphere dominant for speech and language. And on this slide, I've included a superimposition of critical left hemisphere areas for cognition. So I won't read through this slide, but I'll leave it up here for a few seconds to review the cognitive functions associated with each of the lobes of the brain. And what I really want you to take in is the overlap that happens between those centers that are responsible for language and the centers that are responsible for our overall cognition. And also, when we consider the potential impact of a stroke on overall function, we also need to understand how blood supply to the brain is laid out. So we understand when we take a look at the vascular supply that you have these three major arteries that come into the brain, and then they branch off into smaller and smaller arteries. And it's also important to consider the potential cortical area involved. And we talk about this in terms of what areas of the brain are susceptible to damage post-stroke, if the stroke is hemorrhagic or ischemic in nature. So as you can see in the image on the left, in a hemorrhagic stroke, the blood is leaking into the cortical matter, causing toxicity in a very defined area. In the image on the right, in an ischemic stroke, the cortical regions are no longer able to be fed by the blood supply due to a clot. If that clot happens in one of the arterial branches, more of the cortex becomes starved by oxygen. And I think that this image on the right really highlights nicely. And then there's also a very real difference then in terms of the type of stroke and the severity of functional impairment. And it's also important to understand how the trajectories of these two different stroke types are very different. So also keeping in mind that individual differences may definitely affect outcomes and cannot be utilized as a hard and fast rule. But when we take a look as a group, when individuals post-stroke, when somebody is initially admitted to an inpatient rehabilitation program, those with hemorrhagic strokes tend to have a greater severity of impairment compared to those with ischemic strokes, as measured by FIM scores. However, by the time that the individuals are being discharged from inpatient rehabilitation, we see a reversal, and those with ischemic strokes tend to have a greater severity of functional impairment. So we see that shift as an individual becomes further out post-injury. And the reason for this is thought to be that swelling that occurs with bleeding tends to resolve more quickly than compared to healing of the cortical areas that have been starved of oxygen. So now with all of that information in mind, let's apply it to functional impairment. So if a person has a left hemisphere stroke that affects the language areas of the brain, it is likely that key areas affecting cognition can also be impacted. So here I've presented some research articles that show that when adjusting for linguistic factors, that a significant number of persons with aphasia demonstrate underlying impairments in visual spatial reasoning, as shown by this Gilmore et al. Study. Switching attention, we have a 2009 study that's been highlighted here. And we'll move on to the next slide. Another study that shows difficulty with switching attention. And also we're getting into changes in cognitive flexibility as well. So the research also demonstrates that with these underlying cognitive impairments, it can affect an individual's ability to make functional improvements in receptive and expressive language. So for example, we see many people in our clinic that because of aphasia plus difficulty with cognitive flexibility, when they encounter a communication breakdown, they may perseverate or get stuck on always trying to give a verbal response versus trying to use some other augmentative or alternative means of communicating, so such as gesturing or drawing a picture. There's also some research that suggests that a decreased ability to switch between tasks may also be influenced by disruption in the ability to use inner talk. So here's where we're looking at almost like a chicken and egg scenario where because of, somebody might not have intact language skills because there are those underlying changes in attention. But at the same time, there's also some evidence that that language disruption is also in turn causing the cognitive impairment. And so this research is suggesting that decreased ability to switch between tasks may also be influenced by disruption in the ability to use inner talk. So as a speech and language clinician, and what I encourage other speech and language pathologists as well as all rehabilitation therapists is taking a look at what do we need to consider in our assessment. And so as a speech and language clinician, we know that there are standard aphasia batteries that do include non or low linguistic cognitive tasks, but sometimes those are not going to be sensitive enough to really reveal those underlying impairments. So as I said, looking back at Dwight, so our speech and language pathologist completed more in-depth cognitive communication testing. And there are several standardized measures out there that look at things like visual memory, tests that include tasks that allow for return demonstration or miming of tasks to ensure that the individual understands what the task is, and tasks that utilize low linguistic stimuli such as symbols versus letters, words, or even numbers. And also keeping in mind that tests that are out there that look at nonverbal academic performance may also be appropriate to use with this population. So now when we take a look at intervention for these individuals, we must first and foremost keep in mind that no two individuals are going to be the same. And I think that we all know it, but it's always a good reminder. And with that being said, I know I'm talking about the likelihood that of underlying cognitive deficits post left hemisphere stroke, but it's also important to recognize that this does not always happen with an individual. Again, taking a look at what type of stroke that individual had, the size of the lesion, that individual's ability for their brain to heal. Those are all multiple factors that play into whether somebody might show a cognitive deficit. But we also know that the more that we can understand about an individual's underlying cognitive deficit, it's going to set a stronger foundation for more effective treatment planning. So for example, when we are working with somebody who has significant aphasia and we are looking at potential augmentative or alternative communication strategies, if they have difficulty with visual recognition, using a communication book with pictures initially might not be the best method of communication for that individual. And as we are doing our treatment planning, we also have to think about how do we target that cognitive flexibility that sometimes underlies a significant language impairment. So what the research is showing is that language therapy, first of all, is related to a nonspecific positive benefit on overall cognition. But we can also incorporate some low or non-linguistic treatment tasks. Some examples of these are one-back visual recall tasks in which an individual is prompted to recall the last stimulus presented once it has been removed. In our clinic, we've also utilized modalities such as the Dynavision or attention process training. We utilize this to address reaction time, processing speed, as well as task switching and being able to do that in a low linguistic environment. And we can also look at ways to incorporate executive function training into speech and language tasks. So we can incorporate activities that look at construction and manipulation. For example, something that I've frequently done with some of my folks with aphasia post-stroke is something called a tangram puzzle, in which it's 7 triangles as well as, or 5 triangles and a square and a diamond, and they have to arrange them in different ways to create patterns according to a model. So even though it's something that doesn't necessarily have a linguistic load, it's still targeting those underlying processes of problem solving and of cognitive flexibility. So when it comes to formal language therapy too, one of the techniques that can be trialed with individuals with post-stroke aphasia is using a whole script training approach versus targeting expression at a single word level. And so, this kind of also falls in with techniques such as melodic intonation, in which you are trying to recruit other areas of the brain that have not sustained damage to see if the activation of those areas can facilitate language. So sometimes even for a person with a significant language impairment, looking at language as a whole in terms of as a conversation or as a story versus those individual sounds or those individual words can be something that can benefit the person with aphasia. And also, we know that there are a number of various alternative, augmentative, and facilitation strategies that are listed on the slide. And the most important thing for us as to clinicians is it's trial and error. We are always assessing, we're always trialing. As a person continues to recover post-stroke, likely strategies are going to change, that a person is going to be able to take advantage of a new technique that maybe early on in their recovery they were not able to. Something that we are really big on here at On With Life is opportunities for dual tasking. And there is an article, a research article that came out very, very recently, just in this last month, about how dual tasking not only shows improvement in language and cognition, but it can also, on the flip side, show improvement in the motor skill as well. So many of our therapists, whether in an individual treatment environment or in a co-treatment environment, incorporate just things such as walking or talking. How often do we do that in our real life? We do it all the time. Or being able to carry on a conversation while completing a construction task. So it's not only providing opportunity for neuroplasticity, but we're also trying to simulate more of that real life functional scenario. And finally, identification and training of communication partners is absolutely critical for the carryover component, especially for myself, where I work in an outpatient setting. The person served that I work with, I may only be seeing 2 or 3 times a week for 45 minutes at a time. Well, how many other hours are in the rest of the week? And so for that person to be able to practice and utilize those skills. So the communication partner becomes a critical ally in the carryover of language as well as cognition skills. So let's go back and take a look at Dwight again. As I said, I wanted to bring his case back into the fray here to show for speech and language pathology, as well as for occupational and physical therapy too, how taking what might be considered a non-traditional approach to his treatment helped him to really respond, not just to those underlying cognitive deficits, but also to his overall language abilities too. So in speech and language therapy, some of the things that we've been doing is honestly, for him, we've been focusing more on those underlying cognitive skills than we have been what we consider traditional language therapy. So one of the things that we have been doing, because one of the things is, short-term memory. So he hears something, he sees something, but if it's not recorded in some aspect, then he's likely to forget it. At the same time, Dwight also has significant difficulty with being able to type and spell messages. So one of the things that we did was training him on how to use the dictation feature on his phone. So he could state reminders, but then they would show up as texts. And so he would use the dictation feature to create written messages to journal his therapy activities, as well as to set reminders on his phone for upcoming activities. And what was really interesting about this is that as we were doing this training in sessions, he was able to complete a successful return demonstration, but needed multiple trials to do so. And then afterwards needed frequent cueing then to be able to initiate using that strategy. So you see that difficulty in switching tasks as well as cognitive flexibility. So when we were going through and having him journal his therapy sessions, he would do a great job opening up the notes application and finding the correct folder that he wanted to put his note into. But then the first thing that he would do is he would try to type the note in, and we would have to say, no, you use that dictation feature. And we knew that salience wasn't an issue in this case because he would start the dictation, he would say the message, it would pop up exactly as he said, and he'd get excited and he'd say, wow, this is awesome. But then he needed cueing to use it again. And another indicator that he was having a really tough time with cognitive flexibility is that when we were trying to brainstorm different opportunities in which he could set reminders on his phone, he needed a lot of help to be able to generate different situations. And it wasn't that he didn't have these situations, it was just very, very difficult for him to be able to identify and then verbalize those situations. And so, as I said, with our speech therapy interventions, we targeted more the underlying attention and memory impairments. So with Dwight, we have done a lot of attention process training, which for those of you that are not familiar, it is a evidence-based, computer-based training that is done in conjunction with a therapist to target sustained selective suppression and alternating attention. So for the purposes of processing speed, reaction time, again, using low or non-linguistic stimuli, we were really able to get at that underlying slowness of processing. With him, spaced retrieval was a great technique for him. Again, for those of you that are not familiar, helping him to rehearse and encode information and then being able to retrieve it at increasing intervals. So if he was asked to remember something, could he remember it after 30 seconds? Could he remember it after a minute, after 2 minutes, after 4 minutes, et cetera, et cetera. Working memory tasks. So I had mentioned a one-back recall task a little while back. So working memory, being able to manipulate the order of things, being given 3 pictures, could he rearrange them in the reverse order? Could he arrange them in some sort of progressive order? So working with both linguistic material and low linguistic material in this. An example of using linguistic material might be if he's given 3 words, can he restate them in alphabetical order? Medication management, something, again, we don't often think about in terms of traditional aphasia therapy. But when you think about those underlying deficits, how could that impact his ability to independently manage his medications, take what he's supposed to do at the right times, and put him in an optimal position to continue to recover? And then the last thing, from more of a traditional language standpoint, is taking that sentence level, which his reading comprehension really is quite good, but continuing to work on processing that language at the sentence level. When we take a look at occupational therapy, they're continuing to focus on reaction time. They use a lot of the Dynavision. And also recently, we have obtained a driving simulator, and he is spending a lot of time on that as well. And one of the other things that they've incorporated into their treatment too, again, we don't always think of this when looking at somebody with a left hemisphere stroke who appears to have mild word finding deficits, is that he was becoming disoriented when pathfinding in the building. So one of the things that occupational therapy has been working on is just, being able to find his way around the building. If he goes to an area of our campus, is he able to use landmarks to be able to find his way back? So getting into those visual recognition processes. When it comes to physical therapy, lots of dual tasking. And so they continue to see that there is a slowing in gait speed when he is engaged in some sort of cognitive task or language task. And that is also met with increased loss of balance. And also with OT and PT, they're bringing in that cognitive component through making sure that he has the appropriate supports for remembering things like to complete his home exercise program. In addition to the phone reminders that we've worked with him on in speech therapy, can he utilize his email to help him with following through with his home exercise program? Also, use of Amazon Alexa in the home environment to remind him to complete his home exercise program. So as we take a look in closing, what I've done is I've put the objectives for this webinar back up. And what I think that I really want you to take home from this is that really every individual that we work with needs to be viewed like an onion. So different layers, and sometimes that these layers are going to take time to reveal. And so looking back again at our person with a left hemisphere stroke who presents initially with a significant language impairment, we always need to be mindful of if there is that underlying cognitive impairment present. And sometimes that might not present itself clearly until a person gets further along in their recovery. So we always need to be looking at all of those layers. We always need to be working at digging deeper to best serve not just the language needs of our folks with post-stroke aphasia, but also their overall function for all aspects of life. All right, so now I am happy to take any questions.
Thanks so much, Courtney, for all of your insights into today's webinar. So let's transition into the Q&A segment of today's event now. And I see that we have several questions that have already been submitted. So let's jump right into it. This first question is from Angela. And the question is lumosity good for working on memory and attention?
That is a question that I get a lot as a clinician, especially working in cognition. So when it comes to computer-based programs, what the research has found and what what we're saying as clinicians is that we have to be very, very careful with programs that are strictly computer-based that don't have the element of a skilled therapist. And so what the research has found in terms of computer-based programs, and not just Lumosity, but a number of different computer-based programs, is that a person using these would make task-specific gains. And what that's really a fancy term of saying is that they got better at playing the games, but that did not translate into an overall improvement in memory or attention or reaction time. And so what we really stress in our clinical practice is that, we're not saying that computer-based therapies are not appropriate. We're just saying that it cannot be done by itself. There does need to be the guidance of a skilled therapist involved to make sure that the programming is appropriate, as well as to highlight those opportunities for carryover from what they're doing within those computer-based training to real-world function.
All right, next up, let's go to this question from Carl. Courtney, do people with cognitive deficits have less of a response to aphasia therapy?
Yeah, and so the research is saying that that could definitely be the case. So again, when you have those underlying changes in attention and memory, you have those underlying changes in cognitive flexibility, it can make it very, very hard, not just within the session for learning of new skills, but again, there's going to be that carryover piece. So for that person to be able to understand how a skill that has been trained within the confines of somebody's therapy office, how does that play into their interaction with somebody at the grocery store, or if they need to make a phone call? And so, and again, I think that's the biggest reason why I wanted to present this topic to you today, is to say, we really do need to be looking at all of those factors to best serve the people that we work with. And really look at the big picture and look at what is this person's real life going to be like when they are meeting with a friend that they haven't seen in months, or when they have to make that phone call to somebody that they have no idea who they're talking to on the other end. We do need to be mindful of those potential cognitive barriers that might be playing a role in their aphasia therapy. And I would say that this also highlights, too, the need for us as clinicians to have a large toolbox at hand. So not only, a number of strategies that clinicians are comfortable with utilizing and training, but also making that toolbox available to the person with aphasia and their care partners. As I said, strategies are a lot of trial and error. And so not one approach works for any one person. We have to be willing to try out a variety of different tools.
This next question is from Emily. Emily wants to know, how do I incorporate cognitive tasks within my scope of practice as a PT, an OT, or an SLP?
So that's always a great question, because in our healthcare climate, many times we feel like we have to work in these silos. And really our philosophy is, we need to get innovative and we need to be creative about how can we break those silos down. So, a question that I often get as somebody who does cognitive rehabilitation as a speech and language pathologist is, well, how do you bill for it? And so what I encourage my fellow SLPs to do is to think about these skills that you are training and how they apply to language. All of these things that we talked about today, so those underlying attention processes, those underlying memory processes, being able to learn new information, these do have real ties to language. And so I think that we need to be very innovative and forward thinking in terms of how do we connect targeting those underlying skills to being able to maximize a person's receptive language or their expressive language. And we also need to be thinking outside of the box in terms of how we can deliver services. So one of the things that I've encouraged colleagues to do is, if possible, to get your therapy out of that clinic office, then to do it. Go around the campus, work with unfamiliar communication partners, get outside. If it's possible to go somewhere in the community, to do that. And always, your interdisciplinary team are invaluable members. They're invaluable allies. So collaborating with them to figure out, okay, if I'm going to do a dual task and I want to incorporate some motor component, what is going to be the most appropriate and the most safe for that person served, so that you're not putting them at risk, but you have an opportunity to maximize neuroplasticity.
All right. And Courtney, I'll pose this next question myself. You talked a lot about Dwight during your presentation today. So can you tell us whether there has been any recent formal testing done with Dwight that would show improvement in his cognitive function?
So this last week, actually, Dwight is a total rock star. And the reason why I say that, and again, keeping in mind that formal testing is only one piece of the puzzle, but when we redid formal testing, again, using those more in-depth cognitive communication measures, as I said at the beginning of today's webinar, he was falling within the moderate to severe impairment for things like attention and short-term memory. His formal testing done earlier this week indicated borderline mild impairment to normal range scores across the board. So yeah, Dwight is an absolute rock star. He has made stunning improvements, not just in speech pathology, but occupational therapy and physical therapy have noted significant changes in his function as well. So just across the board, yeah, Dwight is doing awesome.
All right, that's great to hear. And I think we have time for one last question. And as we did with the last question, I'll pose this one myself as well. In fact, it's a follow-up question to that last question. Courtney, given Dwight's medical history, what can you tell us regarding what has been done to address prevention of an additional cardiovascular event with Dwight?
And that's a great question, Dave. And that's something that at On With Life, we've really been mindful of as we have been developing our stroke program and really establishing best practices in stroke rehabilitation, is that we have to be addressing prevention. We know that after somebody has had a stroke, they are at significantly increased risk for another cardiovascular event. So part of our therapy is making sure that we're addressing those risk factors with our person served and collaborating with them to problem solve different lifestyle changes. So with Dwight, for example, across the board. So not just speech pathology, but occupational and physical therapy as well. You know, we're making sure that we are talking with him about making good decisions when it comes to diet, establishing a regular exercise program. And again, going back to the cognitive component, making sure that he has supports in place to remind him that he needs to be engaged in that physical activity and to initiate doing that physical activity. Encouraging healthy habits such as, you know, this is somebody who has a history of hypertension, making sure that he's continuing to monitor his blood pressure, making sure that he is continuing to work with his primary care physician and that medications are being reviewed at regular intervals to try and limit those risk factors as much as we can, because we don't want to see another cardiovascular event occur.
Okay, well, it looks like that is just about all the time we have for today. Thank you so much, Courtney. And I just want to remind everyone once again that if you missed any of the earlier webinars in this series, you can find all of them on the On With Life website. And once again, there's no cost to view any of those webinars, and each webinar is good for 1 contact hour of continuing education credit. Once again, after you viewed a webinar, all you need to do is complete the post-webinar evaluation form, and you'll receive your certificate. Again, Courtney, thanks so much, and thanks to all of you for being with us today. That does conclude today's webinar. We'll see you next time. Have a great day.